Hello, and thank you for listening to our presentation. The North American Innovathon Team #1 is addressing the themes of the future of technology and medical learning and the non-traditional collaborative models as we bring you our project titled Artificial Intelligence in Healthcare: Rise of the Digital Colleague. I am Dale Coomerly, and our team consists of Sophie Peliquin, David Settiati, myself, Dean Beals, and Leslie Simon, as seen here in a photo taken during the Montreal Futurist Forum and Innovathon in October 2023. After much discussion and bringing the expertise of our team to bear, our view of the future regarding artificial intelligence in healthcare is that in 5 to 10 years, clinicians will be collaborating with an AI medical colleague and the patient to select optimal therapies for improved patient health outcomes. We set about developing the project outline at the Montreal conference and in the immediate months following. We developed our hypothesis and what exactly we mean by a digital colleague. We did literature search to support our hypothesis, even looking outside of healthcare for AI applications. The team settled on gathering information on knowledge and opinions on AI in healthcare from 2 focus groups, one with patients and one with healthcare professionals. AI was even used to capture their responses and create a summary report. The team met each month since Montreal, recruiting and running the focus groups, analyzing the resultant data, and creating this presentation. As mentioned, we worked with the hypothesis that clinicians lack a trust factor regarding new technologies such as an AI colleague. We know that artificial intelligence applications in healthcare are proliferating at a rapid pace, and trust is needed if they are to reach their full potential. Our desired outcome is to increase clinician trust and speed up the adoption and sustainability of the use of artificial intelligence in the future. Ultimately, we believe that this will help contribute to the strategy for GAME to address the identified learning gap with educational activities. Problem solving in medicine and healthcare can be enhanced by the use of artificial intelligence, which combines computer science and robust data sets. Artificial intelligence-powered algorithms can make predictions to help in screening, diagnosis, and treatment decision-making for patient healthcare. We feel that healthcare-focused artificial intelligence should always be implemented with humans at the center. Humans must supervise, and AI technology should be used as complements to everyday patient care. This setup allows for full control while overcoming some of the limitations and fears that still exist regarding artificial intelligence. This slide highlights what we defined as working with a digital colleague. We believe that multiple processes in the healthcare setting could be owned by the digital colleague, including being pre-trained on current medical databases and triage of the patient's medical information. Of most importance, though, is the ability for the colleague to generate and prioritize key patient insights and make individualized recommendations for the clinician's consideration. We reviewed the current literature regarding artificial intelligence in general. Many AI applications in healthcare are derived from the non-healthcare sector and include automation of administration tasks, clinical decision support tools integrated into electronic health records, and other diagnostic tools to enhance patient engagement in their own care. There have been concerns documented in the literature regarding privacy and the accuracy of source data used in AI applications. Lastly, there is a documented need to overcome misunderstanding and fear towards AI applications. Integration of technology to support decision-making in healthcare started way back in the 1890s with the invention of the X-ray. In the 1980s, we saw the introduction of point-of-care testing technologies such as blood glucose, pregnancy, flu testing, and in the 1990s, the first AI application was used in radiology. Over the last 5 years, there has been an increased availability of clinical decision support tools, offering up knowledge to clinicians via handheld devices and in electronic health records. Many clinicians today are experimenting with ChatGPT a conversational AI chatbot, and looking how best to use it in the care of their patients. We had 3 focus group objectives, which were 1. To understand how much is known by participants regarding the use of artificial intelligence in medical practice within the U.S. and Canada. 2. Collect their perspectives and opinions on the appropriate use of artificial intelligence in medical practices. And 3. To identify the barriers and facilitators to the use of an artificial intelligence colleague. While 2 focus groups were held, one for patients and one for healthcare professionals, the feedback was combined as there were many similarities between the 2 groups. Our results will be focused into 3 primary categories. The first is understanding the opinion regarding the use of artificial intelligence in healthcare and of a digital colleague to support healthcare providers in delivering care. Secondly, we inquired as to the beliefs regarding the appropriate role or capabilities of a digital colleague. In other words, what specific tasks would be appropriate for the digital colleague to perform. Lastly, we asked what barriers the groups foresee to the use of an artificial intelligence digital colleague. Neither of the 2 focus groups expressed significant familiarity with AI applications in healthcare. Applications they were aware of included radiology review of X-rays and telemedicine assisted by chatbots. One clinician said, "AI in my experience is only as good as the information put into it, and if people are reticent to give their information because they don't know where it's going or what people are going to do with it, it's not going to be super useful." When it comes to the functions of a digital colleague, both patients and clinicians see artificial intelligence as an adjunct to augment current medical practice. Appropriate applications include providing current medical information, such as treatment guidelines, screening tools, interpretation of laboratory results, and the latest information on dosing, side effects, and drug interactions. Towards the end of the focus group for clinicians, they suggested that a digital colleague might be appropriate to assist in the diagnosis for complex cases and in the monitoring of such cases. Patients, on the other hand, would support an AI system for submission of symptoms, sort of a triage system that could reduce emergency room visits and provide comfort to patients as to whether or not they need to seek medical care. Much of the discussion with clinicians centered around the appropriate use of artificial intelligence in training and education. Patient stimulation with real patient complexities was seen as an enhancement of current training. Patients said they would accept assistance from a digital colleague when it comes to patient education on their disease and/or their medications. Throughout the 2 focus groups, there was concern regarding AI and that it cannot replace human empathy or emotions. As mentioned in our hypothesis, a foreseen barrier discussed is that of trusting the digital colleague. The clinicians questioned whether the AI could supply quality information, if it was accurate, and if it was evidence-based and free from bias. Bias was also a concern brought up by the patients, with several knowing about inherent bias against African Americans in a recently released clinical study. In trusting the AI, the clinician and the patients must be able to interpret the supplied information for it to be valuable. Several questions came up regarding the logistics of using artificial intelligence in healthcare, such as what medical sources would be used and who would maintain the AI to current standards. Many of the clinicians thought it would be a wonderful facilitation for the work they do, such as insurance coding, but wanted to make sure it doesn't add to the work they do already. Cost considerations came up with patients as well as with clinicians, wondering who would shoulder the overall cost of implementation of a digital colleague. Some benefits and limitations of our study are important to highlight. We utilize currently available technologies such as Zoom and an AI note taker, which made the project to date economical and practical. Some limitations include the fact that this was a quick analysis and that this does not equate to a full qualitative analysis. It was a broad and complex topic, and the small focus groups, which were not random, may not have provided results that are generalizable to the broader population. Our findings are perhaps best summed up with a quote from one of our focus group clinicians. He said, "With the wealth of information that needs to be processed for differential diagnosis, for screening, for laboratories, and interpretation, I see a digital colleague as hopefully a presence next to me that I can ask about specific information that I just have not been able to fit into my brain." Our findings from this initial project could help GAME reflect on its role, if any, in supporting healthcare professionals gaining trust in AI use in education and healthcare as a part of GAME's overall educational strategy. Our hypothesis was upheld with the small data set from 2 focus groups, and we would recommend enhanced research in this area to confirm or refute our small sample outcomes. For example, an additional survey to validate our data with larger numbers and/or additional qualitative data, including having international representation beyond North America. Lastly, the topics of artificial intelligence in lifelong learning and in healthcare should be considered for the agenda of the upcoming Futurist Forums, conferences, and/or webinars. Based on these recommendations, GAME could provide support to conduct a large-scale survey of international patients and clinicians. Data analysis and triangulation of the research findings could lead to the preparation of a white paper or manuscript for potential publication. Given the limitations of the current GAME budget, the total cost here of $7,500 is based on an economical volunteer working model and not an expensive and extensive RFP process. The entire North American Team #1 thanks you for your interest in our report from the 2023 Futurist Forum and Innovathon. Please feel free to reach out to me, Dale Cummerly, at the address listed on the slide. I will end with a quote that I found interesting from Eric Topol's book, Deep Medicine: How Artificial Intelligence Can Make Healthcare Human Again. The quote is, "The greatest opportunity offered by AI is not reducing errors or workloads, or even curing cancer. It is the opportunity to restore the precious and time-honored connection and trust, the human touch between patients and doctors."